I was pleased to be asked to interview Dr. James DeWeese, who I've known for over 35 years, not only as a professional associate, but also as a friend. Dr. DeWeese is Emeritus Professor and Chairman of the Cardiothoracic Surgery, and he's Emeritus Chief of Vascular Surgery at the University of Rochester. He was born in Kent, Ohio. He did his undergraduate schooling at Kent State University and Harvard University, and then came to Rochester for medical school and subsequently for his residency training in surgery. He's been here in Rochester ever since and has spent all of his academic career in Rochester because after finishing residency he joined the faculty. Dr. DeWeese has had an impressive academic career, and he is a complete academician in that he is an accomplished technical surgeon, a researcher, an educator, and an administrator. He has an extensive bibliography. I'm going to just mention a few of the items. He's the author or co-author of more than 280 scientific papers and nearly 100 textbook chapters. He's a member of every major general surgical, thoracic, and vascular surgical society in America. He's been an officer of many, including being president of the International Cardiovascular Society, the American Venous Forum, the Pan-Pacific Surgical Society, and the very prestigious Society for University Surgeons. He's had countless lectureships and visiting professorships, and he's been on the executive committees of many national medical associations, including being on the Board of General Surgery, the American Board of General Surgery, and the American Board of Thoracic Surgery. I first met Dr. DeWeese in 1962 when I came to Rochester to join the faculty of surgery here, but his association with the university begins much before that, and in this interview I'd like to begin by developing that relationship. And Jim, just to get things started, tell us how you decided on a career in surgery and what the circumstances were that brought you to Rochester.
Thank you, Jim. That introduction leaves me breathless. You've said pretty much a lot of what I might have gotten out. And the nice things my mother and wife would believe, so we appreciate what you said. Why did I come to go into medicine first? My father was a doctor. My oldest brother became a doctor, and my second oldest brother became a doctor and a surgeon, and my brother Bill, that is, was my real mentor and probably the reason I went both into medicine and into surgery. My sister married a surgeon as well, so all of the family was medically oriented. So there was no question but what I wanted to be a doctor and a surgeon. When in high school I knew this. Now, as far as finally going into medicine, it started after my interest started at the time when I started looking for where I would go to college, I guess. I was fortunate enough to get a scholarship to Harvard, and this disappointed my father somewhat because I was the first one who had gone east to school, and I think they would have preferred I stayed in the Midwest. But I was there actually only a year. That's a continual year giving me a year and a half credit. At that time, that was in 1942 to summer of 1943, it was of course, the war had started, and it was obvious at that time they had changed the rules, and you could start applying for medical school when you'd completed a year and a half of college. So I had completed mine, and on my way back from Boston to Kent, Ohio, I stopped off at the University of Rochester. I had decided I'd apply to that school because my dentist's son in Kent, Ohio had come to school here. That's the main reason I knew something about it. But when I arrived, I was interviewed by Dr. Whipple and Dr. Fenn and Dr. Adolph and Dr. Berry, George Packer Berry, who was the dean at the medical school at the time, who was not the dean, but was the associate dean for Dr. Whipple, and was the one who in charge of, really in charge of the medical school as far as the students went. I got a letter that summer that if I completed another year of school, that I would be eligible to attend Rochester. That summer, however, an unfortunate thing happened. I was chopping wood in the front yard. An old chestnut tree stump was there, and a chip flew up and hit me in the eye. It caused an internal hemorrhage and a retinal detachment, and so I spent most of that summer being operated on up at the Cleveland Clinic and kind of lounging around, getting the eye back into shape. I had been accepted into the Naval V-12 program at Harvard, but I could not return to the summer and fall session at Harvard because of my injury. Finally, in the fall of that year, I was able to read and go back to school, so I did stay at Kent and get another year of credits. So I now had 2.5 years of credit, and I was still being considered for the Navy V-12 program, but in their examination they determined that because of my eyesight I could not become an officer, but I was eligible to be an ensign. So when I heard this, and that my next thing I would have to do would be to report to Great Lakes for a physical examination there, I let Dean Berry know about that here at Rochester, and he said, "Jim, until you go to Chicago, you come on up here, we'll get you enrolled in medical school." Every person that I've tried to accept here who has been in the Army or Navy programs, that any of the ones we've accepted have gotten into Rochester, and I don't want you to be the first one not to do it. So it was for this reason I did go to Great Lakes. The person who was in charge of ophthalmology at Great Lakes had actually was a good friend, and that also worked at Cleveland Clinic. So when I showed him what had happened to my eye, he just looked at me quickly and said, "Well, you can't become an ensign either. You can't become. You've got to go into. You've got to. You're not medically able to be in the Navy." So I went. Went back to Rochester. Now, Rochester was a great place, as you might know.
Well, I know there were some great names on the faculty in those days, and actually the school was only about 15 years old, I think, when you enrolled here.
1920, well, no, 1925 to, this was 42, so it's
That's
17
about,
years, 15,
all
sorry,
right.
17 years.
All right, but there were some great names associated with the medical school here. Of course, Dr. Whipple was the greatest, being a Nobel Prize laureate. But what do you remember about Dr. Whipple?
Well, Dr. Whipple was a rather stern but gentle Downeasterner, and he actually was, my best remembrance of him is that in pathology he would sit on a stool up. We all sat on stools, actually. It was in a laboratory on Friday morning, and he would quiz us. And he quizzed us by suddenly asking a question about pathology and then pointing to someone, or no, he had a card, and saying, okay, Dr. DeWeese, how would you answer that question? And it meant that every student came to those sessions well prepared, because you never knew who was going to be asked, and that might be your only chance to be interviewed by Dr. Whipple. And so everyone was right on their toes, and answers were given. He'd been actually, I guess the rumor or story is, and or it's true, I'm sure, that he had to make a choice when he finished college as to whether he would go into baseball or go on into medicine in his illustrious career. Anyway, he was a good baseball player. He had his office on the first floor overlooking what used to be the parking lot and is now the big new research building. And that's where we played softball, and he had his desk situated so that he could watch the softball games going on and other activities out on the ground that was outside his office. I see, walking by that area today, I see that this is where there is now a museum, and I'm sorry that it was locked. I didn't get to see what was in it, but that was a simple little office, and that's where you went for your interviews with Dean Whipple, and he was a marvelous man.
Well, Jim, you eventually, of course, went into surgery. Tell us, somebody must have influenced you in that direction, but tell us about the faculty, surgical faculty. Who was chairman at that time you were in medical school, and who were some of the members of the faculty that you remember?
Well, Dr. John Morton, Senior, was, although he was actually called a junior, but he was the senior, had started the surgical department in 1925. And he was still, when I came to medical school in 1944, he was still the chairman of the department, and he was a remarkable man. He was quiet, gentle, but he gave beautiful lectures. In those days, and I'm sorry it doesn't occur any longer, he and all the attendings would give, once a week, would give us a talk. They would talk about things they knew the most about. I still have notes of Dr. Morton's talk on diverticulitis. It was beautifully done. By then, he was actually not operating very much. Later, as a resident, he first assisted at his operations, but we learned a lot from Dr. Morton. The other members were Dr. Herman Pierce, who was when we started to apply for internships, he was the person who had charge of the residency training program. And he was an excellent surgeon and well respected. The one who I had most contact with was Dr. Earl Mahoney and Dr. Merle Scott. Dr. Mahoney was at that time had just started to do some cardiac surgical operations, and he was an excellent surgeon, and it was always my interest in surgery in many ways was because of what I had learned from him. He had been doing cardiac operations, and I remember when I was a medical student and on pediatric surgery, I had read Maud Abbott's Atlas. She was the person who was known as the first pediatric cardiologist at Johns Hopkins, and I had given a little talk to Dr. Clausen, who was in front of Dr. Clausen, who was chairman of pediatrics. And he was interested in this, obviously, and he later told Dr. Mahoney about it. And so Dr. Mahoney knew that I had some interest in it and was very kind to me thereafter. In the other individual that had a lot to do with my training was Dr. Merle Scott, who took over for Dr. Morton in 1954 and became chairman of the department. At that time, he was interested in some thoracic surgery. He was doing operations for esophageal atresia, with the newest operations, because he had worked with Dr. Elliott Cutler in Boston, who had done some of the earliest thoracic procedures. In addition, he was interested in vascular surgery. Now, vascular surgery at that time was primarily lumbar sympathectomy. But they did have a laboratory where they did skin temperatures in patients and showed that things like sympathetic blocks and also sympathectomies could increase the temperature of the foot, and was predictive as to whether a patient might have a response if you did it to a sympathectomy if you first did a spinal block. And so he and Dr. Morton and Dr. Mahoney were all interested also in some vascular surgery. But at that time, vascular surgery was just getting started. They were, all three of them, members of the founding body of the vascular societies, the International Society for Cardiovascular Surgery and the Society for Vascular Surgery. And they were starting in the when I did become chief resident in surgery, we developed, the chief resident was the one who took charge of the graft bank. And the graft bank, the homologous arterial grafts, were obtained in the autopsy room. And Dr. Frank Bauer, my co-resident at that time, and I had to get all of these arteries, and we would freeze them and put antibiotics in with them and put them in an ice box, and then would take them out. And these arteries would be used to bypass occluded arteries in the leg, as well as to replace abdominal aneurysms.
Well, you told us now why, I get the idea now why you decided on eventually specializing in cardiac and vascular surgery. But why did you apply to Rochester?
Oh,
why did you
back,
come here? Let's.
Well, I told you about. Oh well, I
I'm
told you
talking
about medical
for,
school,
for residency
oh, okay.
now.
Well, that was in those days. You applied for an internship, and we didn't have a matching program, but on one evening in March, we would all gather in the entrance, big entrance hall to Strong Memorial Hospitals, to the hospital, and wait there for telegrams, because the people, everybody who had interviewed anywhere, who was accepted, would get, if they were accepted, would get a telegram on that particular evening. So we would, and they couldn't come before something like 8 or 9 o'clock, and they were then distributed, and we got to find out where we were accepted. I had looked at several. The ones that I had been accepted at included Chicago, University of Chicago, University of Michigan, where my brother, who had been a surgeon there for some time, was in the residency and was now in the attending staff, and Johns Hopkins and the University of Rochester. Wasn't accepted at Hopkins, but I could have gone to Hopkins for an unusual reason. The top man in our class, Bill Robertson, had been accepted. He got a letter that he was accepted, and the second man in the class, Bob Pfeffer, also got a letter from Hopkins saying that he could come. Robertson had decided to go into pediatrics instead, so he and we were all standing around, and when he called them and told them that he would not come to Hopkins, they said, well, who else? He also told them at the same time that there were a couple of individuals in his class who had applied who were still interested. And this included another friend, Fred Gollum, and myself. And so the people at Hopkins said, well, have one of them call us if they like it. So by that time, I had decided I wanted to stay in Rochester.
And why?
Been impressed. Well, primarily because of Dr. Scott and Dr. Mahoney and their interest in cardiac and vascular surgery, and the things that it looked to me like that's what I wanted to do. And anyway, I went up to Dr. Mahoney's office. The professors stayed around to see who was coming, or he did that. And we went up and talked to him if we had decided we were going to stay at Rochester.
Now you mentioned a little bit about the type of surgery that was being done in the field of cardiac surgery and in vascular. But what were some of the, you mentioned sympathectomy, but what were some of the other operations that were done while you were, or evolved while you were a house officer?
Well,
in the heart, for instance.
Well, the closed heart operations, although some had been done elsewhere. In 1938, first ductus was done. Dr. Mahoney did the first ductus in Rochester in about 1944. He did it while Dr. Clausen was out of town, because Dr. Clausen, until I had presented this little thing about from Maud Abbott, hadn't really been interested in anyone doing cardiac surgery. So Clausen was out of town, and Max Garber, a pediatrician in town, had a little baby with a ductus and referred it to Dr. Mahoney, and Dr. Mahoney did it, and it went well. So from then on, he was doing some closed heart operations. The first mitral commissurotomies were done in 1948. And by the time I was a resident, Dr. Mahoney was doing a number of mitral commissurotomies. And coarctations, he had done a few of those too. But open heart surgery was just beginning. And the first way of doing it was use of hypothermia, where you would put a baby or an adult into a bathtub filled with ice and cool them down to a temperature of 30 degrees.
Were they doing that when you were a house officer, or was it
no,
shortly after?
This is when I helped Dr. Mahoney, or Dr. Dale, and then I helped Dr. Mahoney on the first of the open heart operations that were done under hypothermia. We were actually doing experiments in the laboratory with dogs at the same time, just after I finished the residency. But during the residency, they weren't being done.
What about the vascular? What kind of vascular surgery was being done? During medical school, it was only, and even first few years of residency, the only thing were sympathectomies and embolectomies. But then again, all of this was starting enough that we had started the homograph bank in 56. That's while you were a
That's
house
why I was
officer.
a house officer in
Right.
56.
So you were using those to replace arteries in humans.
Yeah,
So
and that's the first, those operations were, the early 50s is when everyone all over the country was starting to do endarterectomies, replacement of arteries or bypass of arteries with homographs, and the replacement of aortic aneurysms with homographs. We, as a chief resident, I scrubbed on the first 6 ruptured aneurysms that were performed in Rochester. Unfortunately, they were performed by 4 different surgeons. By the end of the year, I knew more about it than anyone else because I had scrubbed on all 6 of the aneurysms, none of which lived. But that quickly changed as everyone had more experience, and I had gotten in on some of the earliest experience. The other individual here at the time who, as an attending, was doing vascular surgery was Dr. Dale. And Dr. Dale and Dr. Scott and Dr. Mahoney were doing the earliest of the vascular operations as well as the cardiac.
I was going to ask you about Dr. Dale. Now, when you finished residency, you joined the faculty here at the university.
Dr. Scott, one of the best things he did was he said anyone who wanted to stay for a year after their residency that might be interested in research could stay. He would get $5,000 for the year. That would be his salary. Anything that he got from operations on patients would go back to the division. But this $5,000 a year was a bit much more than I'd made as a resident, so that was fine with me. And he also wanted research to take place, so Andy Dale ran the research laboratory first, and then when he left in 58, I took over charge of the laboratory, and then in 61, Dr. Schwartz took over the laboratory. He'd been a year or 2 behind me as chief resident, but both he and I were interested in staying in academic surgery, and we very much benefited from Dr. Scott's providing a laboratory for us, and Dr. Mahoney's interest in research, use of when we were studying hypothermia and how to defibrillate the heart with potassium and so on. These were all things that were going on at that time. Someone asked me at that time why I didn't go away to get some further training if that's what I wanted to do, and I said it's the same all over the country. People are just starting to do this, and I have more of an opportunity here to be in the early stages of development of it than I'd lose a year or two going away, because I wouldn't learn anything more there than I would back here. People were going to the vascular meetings and hearing someone else describe an operation and coming back and doing it. We came back and did them in the laboratory. Many people just came back and started to do them. So it was a time when everything was, it was an exciting period.
Well, Jim, you certainly were a pioneer in vascular surgery, and also in cardiac surgery. What are some of the things that have happened in those fields? Let's speak first of all about cardiac surgery. It really developed very rapidly during the time you were early on in your faculty tenure.
Well, what in the first operations, as I said, were done where we would actually do something inside the heart, were done with hypothermia. And Dr. Mahoney, and assisted by myself and also Dr. Schwartz after he'd finished, we would help Dr. Mahoney on these procedures. And we did about 30 in a period of 2 or 3 years, operations of the simpler types, such as closure of atrial septal defects, and operations where you would dilate or open and take care of a pulmonary artery stenosis. You would make during these operations, you would put the patient who had been in the ice back up on the table, and you would make a chest incision, and you would expose the heart, and you would then occlude the aorta so that no blood would come back in, and the inferior vena cava and superior vena cava so that no blood was in the heart. And then you would open the atrium, and you had 10 or 15 minutes to sew up the septum, because it had been proven that you could safely occlude the circulation for a period of at least 10 minutes and sometimes 15 minutes without having any cerebral problems. Because if you decrease the body temperature to 30 degrees centigrade, you provided further protection for oxygen need.
Well, you established the Department of Cardiac Surgery here at Rochester, didn't you?
Well, this occurred because Dr. Mahoney and I then also in the laboratory worked, first started doing open heart operations using a heart-lung machine. It was one
This was all self-taught here, in a sense.
Well, no, we didn't develop the machine. This had been developed by Dr. Gibbon and Dr. DeWall, but we brought the first machines here and set them up and use them. So the first heart operations in Rochester, open heart operations, were done by us. And as things developed, Dr. Mahoney and I ended up doing all of the cardiac surgery until Dr. Scott Stewart joined us in 1958. And he had had training, and not in 1958, in 1962. He had had training with he worked in the laboratory as a student, and had come back after training at Hopkins and Vanderbilt, and he did the babies after he arrived. And Dr. Mahoney quit operating in 1975. But during those years, all three of us were operating.
It's interesting that you were doing both cardiac and vascular surgery during a good part of your faculty tenure.
Yeah.
And now today, of course, they're separate specialties altogether. Dr. Charles Robb was chairman when I came to Rochester in 1962, and he had arrived here, I think, the year before. What do you remember about Dr. Robb? He was interested, of course, in vascular surgery, and how was your relationship with him there?
He was, Dr. Robb had done the earliest cardiac carotid artery reconstruction for a patient with transient ischemic attacks. He was a phenomenal surgeon, great organizer, beautiful speaker, and a delightful man. Before he came, I had also established a vascular practice as well as cardiac, and he had, one of the other surgeons had spread a rumor that I would be out when Dr. Robb came. I finally accosted this gentleman, and I said, "You don't understand. If Dr. Robb comes, he is going to open new fields, new referrals. I'll keep, I think, most of my old referrals, and he can only help me." And this is just what happened. He came, and I'd always, I'd been a team player, I thought, and was very happy to help him and do research with him and for him, and work with him. And I didn't. And he finally turned over the residency, the mechanics of the residency program to me, and I learned a lot from him, and we got along well, and he was one of the best things that could have happened to me at that time early. He recognized, for example, he did allow us, Dr. Mahoney and I allowed us to start a residency program in cardiac surgery in 1969. In fact, it was because of his suggestion that we did start the program. And he also established the cardiac section, cardiac surgical section, allowed it to become a division in 1975. In vascular,
well, you
Rob also followed. He let us develop, and in the laboratory particularly, and clinically, we were able to develop things together.
Well, you ultimately established a program for certification in vascular surgery. How did that come about? Because, again, you were one of the early proponents of getting certification in that field.
Yeah, in 1969, uh, Lyndon Johnson, President Johnson, had established an interest in a battle against cancer, heart disease, and stroke. And the program ended up, what they finally did was establish some committees from all specialties. And these committees were to look at the optimal needs or optimal resources needed for the improvement and performance of excellent procedures, operations, and treatment. I was asked to be chairman of a committee in 1969 that would look at the optimal resources for performance of vascular surgery. Dr. John Foster and Dr. William Blaisdell and myself met with representatives from the American Heart Association, and we decided, and after writing a paper, sent it around to 50 other people interested in doing vascular surgery, and finally felt very strongly that the way to improve vascular surgery was to get people doing vascular surgery who had been trained in it and preferably certified. And we proposed that the American Board of Surgery and possibly with the American Board of Thoracic Surgery should establish a certification in vascular surgery. I gave a talk on this in Monterey in 1972, and by then the vascular societies were interested in it because the past two presidents had said similar things at their presidential addresses, that too much vascular surgery was being done by people who really weren't trained, and it was showing. And so we, as a result of this, a resolution was sent to the Board of Surgery that we would like them to do this. At that same time, I was elected secretary of the society, and I got to write the letter. This was not very keenly accepted by a lot of people, but it was at first accepted by the Board of Surgery that it would be done because they had just recently done the same thing for pediatric surgery. But anyway, there were ups and downs and over a period of 12 years before something finally occurred. During that 12-year period, I was fortunate enough to have stayed on with the vascular societies as an officer, as secretary of the Society for Vascular Surgery, and finally president, and also active in the International Society for Cardiovascular Surgery, and finally its president. So I was on many of the committees and was able to see finally at the culmination of these 12 years in 1984 when it was decided that you could get a certificate of special competence in vascular surgery from the American Board of Surgery, and that the residency review committees of the American Surgery could also establish accreditation of residencies. And in 1984, we were able to be one of the first 40 or 50 places that offered a residency in vascular surgery. And so this is where we found, this is what we did.
Well, I know you did a lot of cardiac surgery early on, particularly, but you're really known in the field of vascular surgery, Jim, as far as from what I know, recognize. And as I've said in introducing you, you were president of both of the major vascular surgical societies and all. But what do you feel is your most notable professional accomplishment? We talked a little bit here about establishing this board, or certification rather. What do you think has been? You've done a lot of research. You've done a lot of surgery. You've been involved in a lot of policy-making decisions, important policy-making decisions nationally in medicine and surgery. What do you feel are you most proud of?
Well, I guess the thing I'm most proud of is the fact that I've had an opportunity to work with so many fine young residents and have been able to watch a group of over 50 cardiothoracic residents and over probably 40 or 50 vascular people who are, I hope, part of their training and responsible for many of them being very successful people at this time.
What about your research? What research have you done that you thought was the most noteworthy?
Well, I think the work which was done, Dr. Scott, when he was chairman of the department, was the first to start having residents after their second year take a year out in research. And these residents would come to the vascular laboratory where Dr. Dale and Dr. Schwartz and I were working, and they would be spending a year doing research with us. And I think some of the things that have occurred as a result of this is that many of these young men have done some very interesting, good research, which my name appears in the papers of, but much of it was their doing. But the things that we were able to stimulate them to do were first finding the best graft to use for bypassing arterial obstructions in the leg. Many residents have put in a lot of the new prosthetic grafts, the plastic grafts, and compared them with vein grafts, because vein grafts at early on seemed to be very good grafts. And we over a period of evaluating 10 different grafts over a period of years, it became obvious that none of them could be as good as a vein graft. This has remained true to the present time, that the vein graft is the gold standard for grafting of vessels in the leg. In the heart, it's internal mammary artery, but that's, again, it's autogenous. It's something that comes from the graft that is used from the own individual. The other thing was one of the early experiments, when you did put in plastic grafts, showed that many of these grafts failed because they had a deposit develop at the anastomosis, which pathologically is neointimal fibrous hyperplasia. It's a smooth muscle response and build up right at the anastomosis, which causes obstruction of it. And this is something which is initiated research for many laboratories currently, because it is true in all types of arterial and cardiac surgery that the problem is anastomotic buildup of this. And Dr. Green, and when he was in the laboratory and afterwards evaluated various drugs, and it was shown that aspirin could decrease this, and this is why all patients who have grafts, we do put them on aspirin if they weren't on it before, at least one small aspirin a day, because it has been shown that that will decrease the incidence of intimal hyperplasia. And similar studies using radiation, small doses of radiation, were worked out with Dr. Fines, worked on it, and is now being used to try and prevent this from occurring.
What do you
So we didn't make any great discoveries, but we did make some of the earliest observations and of the importance of this.
What do you envision now with the future development of vascular surgery, cardiac surgery?
Well, the most exciting thing from a surgical viewpoint, unfortunately, it's also from interventional radiologist viewpoint, but is the use of internal or endovascular stents to treat areas of obstruction or to treat aneurysms. This is done. The thing that is most interesting to us is that this has turned out to be a good treatment for treatment of abdominal aneurysms, and is now being performed in many centers, and some of the earliest work with this was done also with Dr. Tudor, and Dr. Green initiated a development of an endovascular graft, which is still being used. These are done by, instead of making a big incision in the abdomen, they're done by making a small incision in the femoral arteries and passing up within the artery a graft which has been crunched together, which can then be deposited inside the artery, and as it attaches to the wall with little prongs, and it is then dilated up in place with balloons passed up through the femoral artery inside the graft, and it can be used to put a graft inside the blood vessel, which will separate the aneurysm from the bloodstream. And that's going to, yeah, go ahead.
Well, I was going to, you go ahead and finish what you were going to say.
No,
you think that's going to replace direct operations on the aorta or the arteries?
I think it is going to be available for probably at least 60% of abdominal aneurysms, and possibly more, as means of treatment. It will not be possible for some of the more complicated ones, which also involve the visceral arteries. It's not yet, techniques for doing that within the artery are not yet possible.
Well, the field has come a long way since sympathectomy was the only operation, or essentially the only operation for vascular disease. Listen, recently you co-edited a book called A Band of Brothers. What's the book about, and how did it come about getting the...
Dr. Andrew Dale, who was one of my mentors. I hadn't had a chance to talk much about him, but he was a person who first worked with in vascular surgery in the laboratory, and he was a good friend, He's one of the pioneers in vascular surgery with vein grafts and treatment of venous obstructions, and he is
All of that done here originally?
some of it
Started,
but he
here.
also, when he went to Nashville, he worked at Vanderbilt in the laboratory there. But he, Dr. Dale had many friends who were, he finally called a band of brothers, of people who had been in the early development era of vascular surgery, and he went around and interviewed many of them. And in his interviews, he kind of did the same thing we're doing today, and much of what I've said today appears in my interview in that book. But he did this and had many of them completed, but unfortunately developed lymphoma and died in 1990. Before he died, he asked George Johnson and myself to complete the book, so we interviewed a few more people and got the book together. And it's a very, I think, a very interesting book, because it does give you an insight into how other individuals got interested in vascular surgery and how they developed what they did. It includes many interviews of people that are synonymous with vascular surgery, like Dr. DeBakey and Dr. Cooley and Dr. Conley, Dr. Robb, Dr. E. Scott, Dr. On and on.
All of the great names in vascular surgery. Well, listen, we can't finish this interview without saying something about a subject that I know is very dear to you, and that's golf.
Well,
And
you should have mentioned this with Dr. Dale, because Dr. Dale is certainly my mentor in that phase too, because he was one. I've always been interested in golf and played a lot of it, and had many good friends who are interested in it. I'm responsible for some individuals starting to play golf, like yourself.
Yes.
And but it's a great sport. And
how did you get into it?
I started as a kid. My brother Bill, I lived across the street from Kent State University campus, and we'd go out in the evening and take balls and chip towards trees to see who could get the closest to a base of a tree. And
You still
so
have
many
a good
strokes.
short game, too.
And so that it's been a long-term developing, and finally, as time goes on, as you know, as you get a little older, you don't go as far, and as you know, some people can improve and get better than you, like yourself.
Well, I think our time is up, Jim, and I'll tell you, I learned a little bit about you. I thought I knew a lot about you, but I certainly learned a little bit more.
It's been a lot of fun.
Good.
Thank you.